Thank you. Let's see, we've got a lot of interest in this topic online as well. Actually, a patient of Dr. Nelson's who said they've had a really great experience with Dr. Nelson, but said that they wanted to hear about recurring miscarriages. They say it seems like they don't talk about it because it's such a medical mystery. So I think this is probably posed to everyone on the panel, but perhaps Dr. Nelson, since this person had a good experience, you could answer?
So on recurrent pregnancy loss.
Yeah, recurrent pregnancy loss and what that means, why it's not talked about much.
Okay. I mean, it's a fairly big part of our practice, so just because of our niche, we see a lot of that. So we talk about it a lot. And we, it used to be, and maybe in some clinics still, when patients have had 3 consecutive losses in a row, that used to be termed recurrent pregnancy loss. Now we do see a bit of an increased risk of a pregnancy loss after someone's had 2 consecutive losses. So we personally will start to investigate after 2 pregnancy losses, 2 first trimester pregnancy losses, pregnancies less than 12 weeks. And there's a certain category of things that you can look into for that particular patient population. And so number 1, they have to have normal uterine anatomy. Some patients are born with things we call congenital uterine malformations, where they have half a uterus or a double uterus or a large septum coming down the middle of the uterus. Those things don't typically diminish the chance of conceiving, but they do increase the risk of pregnancy loss. So there can be uterine anatomic things. If the uterus was designed normally, there can be things that develop over time. And sometimes there can be fibroids. You probably heard that term before, but muscular growths within the wall of the uterus that can sometimes impinge or compress and deviate the cavity itself, or overgrowth of the lining of the uterus called endometrial polyps. Those can also potentially diminish the risk of implantation and create fertility issues, as well as increase the risk of pregnancy loss. So you have to have normal uterine anatomy, and that can be assessed through a variety of techniques. The second thing is sometimes patients, when patients ovulate, they're supposed to make the hormone progesterone, which tends to peak about a week after ovulation, which develops the lining of the uterus appropriately for implantation of an embryo. And some women don't make adequate levels of progesterone, either the height of the production or the duration. And so they have inappropriate endometrial development or implantation and increased risk of pregnancy loss. And so there's tests that can be designed to look for these things that we call luteal phase defect. Some patients will have blood factors that can increase the risk of blood clots developing new little placental blood vessels. And the 2 things we look for are potential antibodies that are produced called anti-phospholipid antibodies, we can determine through a blood test. There's also some new genetic information, sometimes on little genes that code for proteins that are involved in the coagulation system. Those genes can have mutations. The mutations diminish the production of the particular protein, or it doesn't work as good as it should. And those proteins in the coagulation system, when they don't work right, also promote blood clot formation in newly developing blood vessels like in the placenta. So blood work can be done to look for those things. That's the third thing. Those can be treated by giving someone a baby aspirin a day, and also a low dose of an anticoagulant, either heparin or Lovenox. So there's uterine anatomy, there's low progesterone levels, there's abnormal things that cause blood clots in your system. One of the more common reasons for pregnancy loss are genetic abnormalities. As Dr. Suri alluded to, as women get older, there's a greater chance when they release an egg that egg is going to be chromosomally abnormal. And either it has too many or too few chromosomes. And when the sperm come in and the embryo now has too many or too few chromosomes, and our term for that is aneuploidy. Aneuploid embryos either won't implant, or if they do, they're going to miscarry early. That tends to be age-related primarily, rising more exponentially after age 35. However, some people have chromosomal conditions called translocations, where one arm of a chromosome is broken off and attached to a different one. So you have all the right stuff, but when eggs and sperm are being formed, they get kind of confused in their formation process, and you're more prone than you would expect purely based upon your age to form either chromosomally bad eggs or bad sperm. So there's genetic issues.